First we go, I think, to the live session. Can we go to the live session in the endoscopic room, please?
Yes, we can.
Yeah.
Hi, good afternoon, Anja.
Good afternoon, Hans.
Tell me your case.
Hannes will tell our case.
So this case is about a 66-year-old female with a recent diagnosis of alcoholic liver cirrhosis, child A. She presented in June with an acute variceal bleeding of the esophagus, for which she had endoscopic band ligation in the acute setting, and she had another endoscopic band ligation session in July and September this year. On the next slide, you can see a picture of the last session in September.
And what do you think? We need another banding session, or can we call it a day with these findings?
Well, I would personally leave this untouched for the moment. There's very little varices to be seen, and also in the stomach, in the fundus, it's very reassuring. I think I would not go for additional banding. You might discuss for a small, but there's very little target for ligation to be seen.
I see a consensus in the studio of my colleagues, which all not yes that this is not an indication for another band ligation session. Yeah, it's really sorry for you, Anja, because we know you're an excellent bander, but it will be for another patient. Still something to add. What would now be the endoscopic follow-up of this patient? I think Thierry Gusteau wants to give a comment on this.
I have a question, Anja. Do you give non-selective beta blockers for this patient?
Yes, the patient is on the combination of non-selective beta blocker. Yeah.
Oh, yeah.
Yeah. I think it's the best way. She bled, and you need to go for the combination to put the patient on a pharmacological treatment and also to have an endoscopic treatment. Do you agree?
Totally agree, and also it's prevent decompensation also.
Yeah, indeed. Yeah.
For example, in our center, we perform liver biopsy if a patient has more than 50,000 platelets and an INR which is below 1.5. So this is a threshold to keep in mind. If it's lower, I think you have to transfuse or look for another solution for your patient. But then there is also this story of hemostatic rebalance, because for a long time we have been thinking that cirrhotic patients were anticoagulated. Now we are beginning to understand that there is really a new hemostatic rebalance in these patients, where there is a new balance between procoagulants and anticoagulant factors. And probably in the end, our cirrhotic patients are rather procoagulant than anticoagulated. And this is important to keep in mind. The problem is that we cannot measure this with our classically used factors of coagulation like INR. Fortunately, new concepts are emerging, for example, the use of thromboelastogram. We do not use it routinely here in the center to perform invasive endoscopy in our cirrhotic patients, but maybe we should, because by just a simple analysis of our blood, we can really measure all the components of the clotting cascade, and we can see if the patient is anticoagulated or not, and we can also see which segments of the coagulation cascade should be altered to do our invasive endoscopy in a safe way. There are not so many data about the use of this technique in endoscopy, but we have this nice study who has compared the use of standard protocol in a hospital where you transfuse platelets or even plasma for invasive procedures in cirrhotic patients, and they compared it to the use of TEC. It was in a very large scope of invasive procedures, but there were some endoscopic polypectomies here. But the message is here that in the TEC group, no patient received thrombocyte or plasma transfusion, wherein the classic group, many patients received this transfusion. And in the end, there was the same level of complications in both patient groups and the same hemoglobin level at the end of the procedure. So maybe this is an approach that we should adopt and should refine in the resection of large polyps in endoscopy.